Different surgical techniques have been employed to treat osteochondritis dissecans. They may involve multiple options like microfracture, autogenous or osteochondral autografts, allografts, or autologous chondrocyte implantation. When we are dealing, first and foremost, the more common is usually microfracture, as this is an easy way out using a drill bit in the case if the physis is closed, or if the physis is open, we can use smooth K wires which can be drilled via retrograde fashion or anterograde fashion as well. Now, retrograde means you're going through the lesion from the joint up to the intramedullary cavity, or you can go with anterograde fashion as well, that is you can come from the medullary cavity right up to the lesion where the lesion is, and actually a path is created between the lesion and the intramedullary cavity so that stem cells can flow in and form a fibrocartilage and therefore plug the lesion as a whole. The other technique is internal fixation. This can be done by use of arthroscopy, and mostly the arthroscopy is actually used to do this internal fixation by use of Herbert screws or osteochondral pegs to stabilize the unstable lesion. Or we can also go for other techniques like osteochondral grafting. Now, grafting could be in form of an autograft, that is if it's a very small lesion less than 2 to 3 centimeters square and the lesion is at the medial femoral condyle, we can take some cartilage from the lateral femoral condyle and use it to plug the lesion over the medial femoral condyle. But for example, if the lesion is very large, more than 2 to 3 centimeters square, which actually means if you take a lot of cartilage from the other femoral condyle, that could lead to donor side morbidity and lot of problems over the site from where the graft is actually being taken. Therefore, we may have to go for osteochondral grafting in form of an allograft, which may be required as well. Or we can, if it's a very large lesion and high demand patient, we can go for autologous chondrocyte implantation as well. That area can be used to actually implant the chondrocytes over there, which can actually grow into form of a cartilage and eventually plug the lesion and cure the patient from the problem as well. Therefore, multiple different techniques can be employed, but the decision actually depends upon two things. What is the size of the lesion? Is it a small lesion less than 2 to 3 centimeters square, or it's a large lesion when the size is more than 2 to 3 centimeters? For the small lesions, we can go for microfracture technique, internal fixation as well. For the large lesion, we may have to go for osteochondral autograft, allograft, or autologous chondrocyte implantation as well. But if it's a low demand patient, we can also go for microfracture or internal fixation in a large lesion as well. Therefore, one has to get detailed history, examination, understand the lesion, and understand actually the demand of the patient as well. Whether patient is a low demand or high demand, and then whatever the clinically suits best, we have to go for that sort of a surgical technique. And lastly comes the periosteal patches. If it's a very small lesion, and usually in the case of children, we may have to go for, we can apply the periosteal patch because children usually have a thick periosteum, and a periosteum can be stripped from the bone and can be applied over there. Therefore, usually in the children, we may not require any surgery, but if we are going for surgical technique, then periosteal patches are highly important and can be very good in the case of especially the adolescent age group or the age group where the actually physis is still open. We have briefly covered osteochondritis dissecans. It's mainly a disease of young adults, especially the skeletally immature children. It comes with these vague symptoms. The problem is with the underlying subchondral bone as well as the cartilage, and symptoms may include mild catching, glecking, or even the effusion as well. Usually, initially the symptoms may be very vague, and non-localized pain is maybe present in the knee joint. Gradually, the mechanical symptoms may appear and the effusion becomes more frequent. And once the children do come, the primary complaint is that the problem starts right after activity. And usually when we get an x-rays and MRI done, we are able to see an osteochondral lesion which may present with for osteochondral fracture, or it may be represent as a loose bodies in the knee joint. Therefore, treatment is mainly directed at whether the physis is open or closed. When the physis is open in skeletally immature children, usually non-operative treatment is more than enough for 70 to 80% of the time. And we may have to go for certain operative treatment in the case of children only. But in case of young adults or old age groups, we have to apply certain treatment which may include use of microfracture technique, use of chondral resurfacing, or we may have to go for osteochondral autograft, allograft, or even autologous chondrocyte implantation as well. And if the things do not improve and eventually arthritis does develop, and may we eventually land up with total knee replacement in these patients as well. Thank you very much. Keep watching sqadia.com.